due to factors such as modern lifestyle, environmental changes, and dietary habits. Allergies have become a growing health concern affecting people of all age groups. In India, approximately 20 to 30% of the population suffers from at least one type of allergy. Hence, as a doctor, you must be well aware of the pathology, symptoms, and management of allergic reactions. Since although they may present as mild, delayed reactions developing as long as 48 hours after exposure, but sometimes the allergic reactions may be immediate and life-threatening, developing within seconds. Hello everyone, welcome to the series on medical emergencies in dental practice. Today I will be discussing about allergic reactions and anaphylaxis. So let's start with some basic concepts. Allergy is a hypersensitive immune response to substances that are usually harmless. These substances, known as allergens, can be pollens, dust mites, certain foods, insect stings, or medications. An allergy occurs when the body's immune system sees a substance as harmful and overreacts to it by releasing chemicals. Hence, it is also known as hypersensitivity reaction. Next, coming to the types of allergy. Type 1 is IgE mediated, that induces degranulation of mast cells and causes localized and systemic anaphylaxis, seasonal allergies, and eczema. Type 2 is IgG mediated, wherein cells are destroyed by either activation of complement or cytotoxic T cells as seen in transfusion of mismatched blood. Type 3 is immune complex mediated, wherein antigen-antibody complexes are deposited in tissues and it is involved in glomerulonephritis, rheumatoid arthritis, and SLE. Type 4 is cell-mediated, involving the helper T cells and is commonly associated with contact dermatitis and autoimmune diseases. In this video, we will focus on type 1 allergic reactions. These can be divided as localized reactions and generalized reactions. The localized reactions may be limited to the skin and respiratory tract, or they may progress to present as systemic or generalized anaphylaxis. First, we will look into the clinical manifestations, that is, how the different allergic reactions present clinically. Skin reactions generally present as localized areas of redness such as rashes and flushed skin, urticaria or hives, pruritus or itching, and angioedema. Also, the skin reactions may be grouped as delayed onset skin reactions that take about 60 minutes or more after antigenic exposure, and rapid onset reactions that develop in less than 60 minutes. Now coming to the respiratory tract. The allergic reactions may involve the lower respiratory tract resulting in bronchospasm, that is constriction of bronchial smooth muscles, and inflammation of airway mucosa. Or it may involve the upper respiratory tract presenting as laryngeal edema, which is a life-threatening condition with swelling of the vocal cords. The lower respiratory tract reactions present as respiratory distress, wheezing, mild dyspnea, and cyanosis. There is flushing, perspiration, tachycardia, and greatly increased anxiety, and the patient uses accessory muscles of respiration. In case of upper respiratory tract involvement, there is respiratory distress and inability to speak. The patient produces high-pitched crowing sounds. In case of partial obstruction, there will be stridor, while there will be no sound in complete obstruction. Little or no movement of air can be heard or felt through the mouth and nose despite exaggerated chest movements. There is cyanosis and loss of consciousness occurs due to hypoxia or anoxia. Now let's look into the generalized or systemic anaphylaxis. It begins with patient complaining of malaise or feeling of impending doom. There will be skin reactions such as flushing, urticaria, and pruritus of the face and trunk, nausea, vomiting, abdominal cramps, and urinary incontinence, dyspnea, wheezing, and stridor, cyanosis of nail beds and mucosa. The cardiovascular manifestations include initial tachycardia followed by hypotension, cardiac dysrhythmias, and cardiac arrest. Ultimately, there is total airway obstruction and loss of consciousness. Now coming to the management part. Although the management is somewhat similar in most cases, However, I will discuss them separately for better understanding. In case of allergic skin reactions, all dental procedures and all drugs in use should be stopped immediately. Vital signs such as pulse, BP and respiratory rate should be monitored every 5 minutes, and emergency drugs should be started. There are two choices of drugs that can be used depending on the clinical condition. These include antihistamines and epinephrine. Antihistamines like diphenhydramine or chlorpheniramine are recommended when there is no cardiovascular and respiratory involvement or after resolution of cardiovascular or respiratory symptoms. The doses for diphenhydramine is 50 mg for adults and 12.5 to 25 mg for children. Chlorpheniramine is given 4 mg in adults and 1 to 2 mg in children. Both these drugs can be given orally in case of mild allergy or intramuscular in case of moderate allergy and for more prolonged clinical activity. Epinephrine may be required in case of rapid onset reactions and is recommended when there is involvement of respiratory and cardiovascular systems. The dosage is 0.3 ml of 1:1000 concentration intramuscular or subcutaneous. It can be administered every 5 to 20 minutes as needed up to a maximum of 3 doses. The preferred intramuscular injection site is the vastus lateralis muscle located on the anterolateral aspect of the thigh. In addition, oral antihistamines should be prescribed for 2 to 3 days. The patient should not be discharged until the clinical signs and symptoms have resolved and should not be allowed to leave the dental office alone or operate a motor vehicle. In case of rapid onset reactions, the patient physician should be consulted and the patient should be observed for 1 hour before discharge. Coming to lower respiratory tract reactions, all the dental procedures and all drugs in use should be stopped immediately. The emergency team should be activated and the patient's physician consulted. The patient is placed in a sitting or semi-erect position and the circulation, airway and breathing are assessed. 0.3 ml of 1:1000 epinephrine intramuscular or subcutaneous is administered and it can be repeated every 5 to 20 minutes as needed, up to a maximum of 3 doses. The point to note here is that epinephrine does not relieve bronchospasm caused by leukotrienes. In such cases, other inhalation bronchodilators such as albuterols may be used. Oxygen is administered at a rate of 5 to 6 liters per minute by face mask or nasally. Antihistamines such as diphenhydramine or chlorpheniramine are recommended to minimize the likelihood of recurrence of bronchospasm by occupying the histamine receptor site. The patient should be observed in office for at least 1 hour. Oral antihistamines are to be prescribed for 2 to 3 days and the patient should be shifted to a hospital for further observation and additional treatment. Similarly, in case of upper respiratory tract reactions, all dental procedures and all drugs in use should be stopped immediately. The emergency team should be activated and patient's physician consulted. The patient is placed in sitting or semi-erect position if conscious, while supine position with feet elevated is more appropriate if the degree of laryngeal edema is significant and consciousness is altered. Proper positioning is followed by assessment of circulation, airway and breathing. The patient's neck is extended via head tilt chin lift or jaw thrust chin lift followed by insertion of nasopharyngeal or oropharyngeal airway. 0.3 ml of 1:1000 epinephrine IM or subcutaneous is administered and can be repeated every 5 to 20 minutes as needed up to a maximum of 3 doses. Oxygen is administered at a rate of 5 to 6 liters per minute by face mask or nasally. The vital signs are to be monitored every 5 minutes. Antihistamines and corticosteroids are recommended after clinical recovery, that is airway improvement, normal or improved breath sounds, absence of cyanosis and less exaggerated chest excursions. Cricothyrotomy is indicated when total airway obstruction cannot be reopened at all or not in time by epinephrine and other drugs. The patient should be shifted to a hospital for further observation and additional treatment. Management of generalized anaphylaxis is very much similar to that recommended for laryngeal edema, since the usual cause of death is vocal cord edema and laryngeal obstruction. All dental procedures and all drugs in use should be stopped immediately. The emergency team should be activated and the patient's physician consulted. The patient is placed in supine position with feet elevated. Circulation, airway and breathing are assessed and maintained using basic life support measures. 0.3 ml of 1:1000 epinephrine, intramuscular or subcutaneous, is administered and can be repeated every 5 to 20 minutes as needed, up to a maximum of 3 doses. Oxygen is administered at a rate of 5 to 6 liters per minute by face mask or nasally. The vital signs are to be monitored every 5 minutes. Antihistamines and corticosteroids are recommended once there is improvement in patient's condition. Cricothyrotomy is indicated when total airway obstruction cannot be reopened at all or not in time by epinephrine and other drugs. The patient should be shifted to a hospital for further observation and additional treatment. At last, some important points to remember about epinephrine. The preferred intramuscular injection site is the vastus lateralis muscle located on the anterolateral aspect of the thigh. 1:1000 epinephrine concentration should not be used intravenous. 1 ml should always be diluted with 9 ml of diluent to produce 1:10,000 concentration, which is titrated IV at a rate of 1 ml, that is 0.1 mg per minute. The maximum dose of 1:10,000 epinephrine should not exceed 5 ml. Epinephrine is relatively contraindicated in elderly patients and in case of coronary artery disease, hypertension, angina pectoris, and life-threatening tachydysarrhythmias. In these cases, antihistamines or corticosteroids, whichever appropriate, can be considered. That was all about allergic reactions and anaphylaxis. However, it is recommended to refer the updated and standard guidelines regularly to keep yourself up to date with the emergency protocols. In the upcoming videos, I will take on another medical emergency and its management. Till then, if you found the video helpful and informative, then do like the video, share it with your friends and subscribe the channel for more such videos. Also, you can download our app for more details and notes on dental and medical topics.